Welcome to the show, Your Healthcare. In this show, we discuss medical-related topics and issues. Today, we're going to talk about arthritis, specifically on your lower extremities arthritis, your hips and knees, which are affected the most since we walk on our legs, not on all four. I will also give you an update on the most advanced techniques in total joint replacements for knee replacements as well as hip replacements. I will show you the instrumentation that we use for traditional knee replacement, what we actually utilize in the operating room to perform a successful knee replacement for you. In addition, we have a colleague and a personal friend of mine, Matt Shelley from Zimmer Capital, who has brought this instrumentation for us. He's a representative of the company, which helps me at every case that we do. It's important to work as a team, but we'll begin first with the basic. Arthritis, what it is, what we can do for you, what are the different treatments available there, all the way down to surgery, which is a total joint replacement. I'm Dr. Amit Lahav. This is Your Healthcare. Stay tuned and we'll talk about arthritis and updates in total joint replacement. Welcome back to Your Healthcare. I'm Dr. Amit Lahav, and in today's show, we're going to talk about arthritis. Arthritis of your knee and arthritis of your hip. What treatments are available, and all the way down to when all conservative management has failed, and you may need a total joint replacement, such as a knee replacement or a hip replacement. I have brought different models and the actual replacements for you even to see, and what it entails to go through the surgery of a knee replacement. I'd like to really give you a good background of arthritis. If we can go to the presentation, please. We're going to go specifically over total joint update, starting with the basics. What is arthritis? What are the treatment options? And update in joint replacement. The basic for joint replacement is to bring you back to the activities that you like to do. But what stops you from it? Arthritis, specifically of the hip and the knee, your lower extremity arthritis. There are millions of Americans who have arthritis, and there's actually many, many different types. But I will go over the top three, which comprise really more than 95% of the arthritis that we diagnose. Well, how do you get arthritis? Aging as you get older. If you're heavier, you place more stress on your lower extremity joints. Any joint injuries, even long time ago from sports, work-related accidents, and so forth. And some genetics. Obviously, you can't change where you're born and who you're born from. And if there's a family heritage, then you are more susceptible to get arthritis. Some of the symptoms from arthritis are pain, stiffness, decreased mobility. You may notice that your knee doesn't extend all the way, or your hip doesn't rotate the way it used to be. And unfortunately, with arthritis, the symptoms worsen over time. Arthritis can also have emotional impacts as well, not just physical impacts. Depression, things you couldn't do before, and now it's actually getting worse. And this can affect really your relationship, productivity, your work, and your activities. So what is arthritis? Arthritis is really when the cartilage begins to break down, and this is just a picture of a knee. It's the cartilage breaking down within your joints. So you wear it down to essentially bare bone. There's three basic types of arthritis. Osteoarthritis, which is the most common. Inflammatory arthritis, things like rheumatoid arthritis, lupus, psoriatic arthritis, and traumatic arthritis. So osteoarthritis, which is the most common type of arthritis, is considered a non-inflammatory degenerative joint disease where the cartilage essentially breaks down. And the cartilage, again, is that cushion in your joint that prevents bone on bone from grinding. So there is a knee on the right and there is a hip on the left of the screen. The areas that are pointed to there where you see sort of a reddish hue, that's bare bone. So the cartilage, which is the white, essentially worn down to bare bone. And there's nerve endings in the bone, which now when they touch the other side of the joint, that hurts. There's no more of that white cushion called the cartilage. So in a healthy hip here on the left and an arthritic hip on the right, again, the cartilage wears down, which gives you sort of that pain of grinding bone on bone. Rheumatoid arthritis, which is more of inflammatory arthritis, this is just a picture showing arthroscopy of the knee, where the synovium, or the lining of the joint, is very irritated. It's very red. It's almost like a very angry joint, or a pissed off joint. And when that angry joint is there, it releases chemicals that actually injure the cartilage. So the inflammation within the joint in inflammatory arthritis causes chemicals to be released that thicken the synovium and then damage the cartilage, as opposed to osteoarthritis, where the cartilage just wears down. So here in rheumatoid arthritis, the reddish portion there is the synovium, or the lining of the joint, which produces chemicals that hurts the cartilage. In very severe rheumatoid type of arthritis, you can see different deformities in the hands, as seen here. And in inflammatory arthritis, unfortunately, it affects multiple joints, where osteoarthritis generally affects one or two joints. What about traumatic arthritis? When we're very active, especially as young individuals, and even those that are young at heart, anything can happen. Different incidents, different accidents. Maybe we used to do some BMX racing or biking, as I used to do, and it doesn't exactly work at the end the way you expected. That is a trauma. If maybe we thought that we could leap like Spider-Man and don't quite make it, that is a trauma. That can haunt you later on in life. So in traumatic arthritis, what happens, you injure the blood vessels within the bone, which essentially nourish that bone, and that part of the bone can die, leading to collapse of the cartilage over it, and that is what is traumatic arthritis. So the bottom line is, how do we ease the pain? If you do have arthritis, no matter where it's coming from, what do we do? Well, anti-inflammatory medications, as we call it, NSAIDs, non-steroidal anti-inflammatory drugs, pain medication, sometimes a slippery slope, steroids, both oral and injections, lubricant injections, exercises, heat or cold, bracing, and finally, surgery. The bottom line, again, is to maintain the function. We want to be able to bring you back to the things that you enjoy doing before your joints became symptomatic. So the number one goal is control the pain. Number two is you want to optimize the function. And number three is you want to educate. The more that you know about your health, the better you will be about making the right decisions for you. So what are some of the non-surgical treatment options? Well, joint and muscle exercises to improve flexibility and strength is very good. Weight management, injections, anti-inflammatory drugs, and again, different type of modalities like heat and cold. First step is you got to modify your activities. If you used to run and it bothers you to run, perhaps doing something like biking or elliptical machine would be better for you. Regular low-impact exercise is better, such as swimming, biking, and elliptical. So the exercise are regular, low-impact range of motion, which will benefit you and keep your joints mobilized. What about bracing? We can see the bracing for, especially on the knee. You may see a lot of people walk around with different type of braces. The problem with bracing is compliance. For arthritis, we sometimes use what we call an unloader brace. It's a brace that pushes your knee into a position to weight bear on the more normal side of your knee. The problem is you have to wear this brace all the time. And if you have more of a conical looking leg, sort of thicker on top and slimmer on the bottom, a lot of the braces slip down, making it uncomfortable. So it's definitely an option, but for some people it doesn't really work as well. And again, compliance is the basic struggle or the variable. What about steroid injections? These are injections especially for the knee, although it can be done for the hip as well. A steroid, or what we consider cortisone type of injection, that's injected into the joint. The way I like to look at this is it's almost like you're taking an anti-inflammatory medication like Motrin, ibuprofen, Aleve, and putting it directly in the joint. You will feel better, but it doesn't treat the underlying problem of the arthritic part of your joint. And the problem with a steroid, it's a double-edged sword. It can help you, but if you use too much of it, it will actually injure the remaining cartilage. What about these lubricant type of injections called viscosupplementation injection, or some people consider what they hear like rooster comb type of injections? These are lubricant type of injections, almost like an oil change in your car. The engine is getting a little bit rusty, but you want to give it sort of the best oil into that engine. And same concept here in the joint. It gives a more sort of thicker, viscous type of fluid into the joint, and it's anywhere between 1 to even 5 injections, which can be done once a week to give so this thicker joint fluid into your joint and hopefully give it some type of cushion which can help you. It works really better in maybe mild to moderate arthritis, not when you're really essentially bone on bone. What about some of the things you go to health food stores like glucosamine, chondroitin, and there's tons of these things on the shelf. And really the bottom line with these, what I tell my patients, is if you take it for 4 or 6 weeks and you stop it, if you don't feel a difference, don't spend your money on it. Now for some people, especially glucosamine, it's what can be helpful. There are some studies that may have shown that there is some beneficial effect. The amount of glucosamine you want to consider is 1,500 milligrams per day. That is sort of the basic number to use. All the other ones are really a give and take. They may help some people, maybe not. And the thought behind it is some of these byproducts give almost like an aspirin-like effect, which is why you feel better. Despite the marketing and all these type of substances, it does not replenish your cartilage. Your cartilage does not grow back. After your early age as a child, whatever cartilage you have, that's the cartilage you have for the remainder of your life. What about other supplements, antioxidants, vitamins? These are all basically for a good nourishment and good nutrition. It doesn't particularly help the cartilage grow back. Again, as I said before, whatever cartilage you have in your young years, that's a cartilage you have to continue for the rest of your life. So then what happens when you come down to surgical options? You failed that conservative non-operative treatment. There's things like arthroscopy, osteotomy, where we actually cut your bone and then realign your joint in order to weight bear through a normal side of the joint, partial replacement, and then also total joint replacement or complete replacements. So knee arthroscopy has been very popular in the past, and it's sort of cleaning out your knee. It's not really as effective for the hip. The problem is this cleaning doesn't change the arthritis that you have. It doesn't give back the cartilage. It may take some of the sort of inflammatory mediators away from your joint, making you more comfortable, but it's only a temporary type of procedure at best. Other type of options like osteotomy, as you can see on the right side, it's an x-ray showing the white, which is the metal. What we did here is we actually cut the bone, we realign the tibia or your lower bone, and then we put a plate and screws to hold into that position in order for you to weight bear through the more normal side of your knee. There's an inner and outer part of your knee, which the problem with this, we do it in more younger individuals, but it can complicate joint replacement later on in life. It could be essentially a temporizing procedure. So let's jump into hip replacements. Let's say you failed everything and you are a candidate for total hip replacement. If you look at the left, it's an x-ray of a normal hip showing the joint space still maintained between the ball and the socket. And on the right side, you lose that space. You get that white appearance where you're grinding the bone on the bone. So in a hip replacement, we essentially give you a new ball and a new socket. If this is a cadaver looking at the hip exposed, the socket is on the right and the ball's on the left. There's a ligament in the middle, which is a normal ligament in the ball, but the ball essentially looks very white. That's normal cartilage that's there. Here you can see the redness, or where the white is actually disappeared, and you're down to bare bone. That is arthritis. There's nerve endings there, and whenever you place a step, that bone touches the bone of the socket, which now causes you pain. So in a hip replacement, we give you a new ball and a new socket, and I will show you a model of this as well, and really the real thing. So the components essentially are a type of a stem, and there's multiple stems out there, and types of cups with different liners. There's also different balls, and they're different sizes. Bigger balls have some benefits. I like big balls because it decreases the risk for dislocation. And big balls are not just for guys, big balls can be for women as well. How about metal on metal? You may have heard out there that there's been some catastrophic failures of metal on metal. The reason this came about was because traditionally we use a plastic liner, and the plastic liner can wear out over time, like the brake pad in your car can wear out as you're using it. So the thought behind metal on metal was, well, we use a hard surface, there's no plastic, this will not wear out. Theoretically that's true, but within the body, unfortunately, the metal on metal releases ions which can destroy the soft tissues around your hip. And unfortunately, we've seen a lot of early failures of the hip when we revert back to the traditional ways, which are metal on plastic. So we have to revise your hip back to metal on plastic. And that is generally what I use in my patients anyway. I use metal on plastic. It's been around for decades, and it's worked well for many, many years. What about ceramics? Same thing, hard surface. There's no plastic. It's not going to wear out. Theoretically, that's also very good. Unfortunately, some of the earlier ceramics, like the vase on your shelf, if it falls down, it breaks. And a higher impact to the hip, unfortunately, caused some of these balls to break. And unfortunately, that necessitates surgery right away. All of the new ceramics we've had over the past several years are much, much better. You can drop them off from a 5-story building and they will not crack or even scratch. So there is a benefit of that. The only thing about ceramic on ceramic is that it can squeak. Literally, you can hear a person walking down the hall. If they have a ceramic bearing, it sounds and they cannot hide it. But ceramic on plastic is also very beneficial and has shown very good results in more recent studies. Also, the stems that we used, custom hip replacement. We use different stems that can actually match your anatomy. Everybody's a little bit different. But now the stems that we have are able to actually replicate more of your normal anatomy. How about minimally invasive techniques? Now this is, again, ways to do your replacements. And the goal of minimally invasive joint replacement is really to minimize the amount of soft tissue damage. It is not about the size or length of the incision. It's what we do inside the body that makes the difference. And that's a common misunderstanding. And there's different approaches to the hip. There's anterior, or approaches from the front, posterior, approaches from the back or from the side, 1 incision, 2 incisions, and different lengths that we can use. And that really depends on your body habitus and your deformities. So how do I know if you're a candidate for a mini incision or a less invasive or a smaller type of incision? Well, if you're heavier, we got to see what we're doing inside. So the incision has to be bigger so I can see how to put the prosthesis inside. So I base it on the patient's obesity. If you have a history of blood clots in the past, you can't struggle through a small incision shifting it around because that can place some stretch on the vessels, which can lead to higher risk of blood clots. If there's medical conditions that make you not a healthy subject for surgery, you really want to make a sort of a bigger incision, get in, do what you have to do, and then get out, and not struggle longer working through a smaller window. And for revision type of surgery, if you had surgery before, we generally need a larger incision just to see again what we're doing. How about a partial replacement? I'll briefly discuss that, which is really replacing only one portion of the knee, leaving the rest healthy knee behind. So if it's only affecting sort of the medial or inner part of your knee, as shown on the left side of the screen, all we do is replace that part of the knee. Everything else stay the same. It does not mean you're not going to get arthritis later on, and if it does occur, this essentially has to be converted to a total joint replacement. This is just an x-ray showing the knee from the front on the left and from the side. The white is actually the metal. This is a partial replacement where we only replaced the inner portion of the knee, leaving the rest of the knee your own native knee. Well, what happens when you go to a total knee replacement? Here, when you have a knee replacement, you have no more arthritis. Arthritis is gone. We replace everything in your knee. And the way I like to consider knee replacement is really a resurfacing type of procedure, which I will show you soon. And here, if you have arthritis in the knee, the x-ray all the way to the right side shows again the white, which is the metal, and that replaces your full knee. The space in between the two white components is essentially the plastic, which acts as your new cartilage. This is a side view on the left and a frontal view on the right of a knee replacement. One of my patients, which shows again the white is the metal, which is the prosthesis, essentially giving you a new surface to walk on. So how do you know if you have arthritis? Well, x-rays are very helpful, as well as physical examination and your history. The x-ray on the right shows bone on bone of your medial or inner compartment. You can see there's no space between the bone. That is arthritis. And with knee arthritis, we can also see a lot of deformities, sort of a knock-kneed or bow-leggedness, which depends on the deformity and the arthritis you have. This can get repaired and realigned during surgery. So in a knee replacement, again, it's more of a resurfacing type of procedure. It doesn't mean we cut out your knee. Essentially, we give you a new surface to walk on. This is just one of my surgeries, going from the upper left to the bottom right, showing the arthritis that you have in your knee, and there's a loss of that white or cartilage that you have. The trials are in the middle, and then at the very bottom, that's the brand new shiny knee that the individual has, and that's part of my team all the way on top, me in the middle. Being very happy, allowing me to help individuals go back to their activities. So here again showing different type of knee replacement, but again there's a component that goes in your thigh bone, a component goes in your shin bone, and then the plastic in between. We also have high flex knees, knees that can bend a lot, and we've done that also with Zimmer. There's different type of ways that we can actually get more motion, but it really depends on how much you push after a knee replacement. There's also gender-specific knees, males versus females. We are a little bit different. This is also something that I do, and we base it on the individual to give you the best knee that we can. We want to essentially realign your leg, balance your knee, and give you back a successful type of replacement. But what about future options like robotics and navigations and custom-made type of prosthesis, which is specifically made for you? There are different type of blocks where we can use things like CAT scans and MRIs to try to replicate your anatomy and give you the best fitting type of replacement. These are different blocks that we put during surgery in your knee and make the appropriate cuts to give you more of the perfect joint replacement. And again, there's different types of mechanisms we could do this in order to try to give you back a more custom-made, personalized knee. What about computers in navigation and robotics? This is something that I've also used. And in navigation, we essentially use a computer to determine where your limb is at in space at surgery, as well as the different type of instruments that we use to make the appropriate cuts. So before we actually make the cuts, we look at the computer screen and determine what we want. And this can be even to a significant of a half a millimeter or half a degree, that I can change the way I'm going to make the cuts in the bone in order to try to position the best implant for you. So how close do you really want to get to perfect? Well, you really want to get to perfect, as close as we can get. You want that fit to be exactly as a glove on your hand. On the left side is a side view of the knee replacement, again one of my knee replacements from one of my patients, and on the right side is a frontal view. It's a perfect fit. That's what you want to get. And using computers, we can actually assess during surgery where the blue line is your range of motion in your deformity before surgery, where the red line is actually after we fixed you and put a new replacement in. You can see how close to zero we can get. So your knee is balanced. Even before we leave the operating room, we already know where you're at. So in a knee replacement, the precision of how the cuts are made of the bone and how straight the implant is really has the longevity of the knee replacement, how long that will last. So here we use, again, GPS type of technology. Well, we use it in our cars, we use it in satellites. Well, why can't we use it in the operating room? And we can use robotics, which are placed on your thigh bone in order to position, based on the computer, where I will make the cuts for you. And here is a view on the right side of the screen where the computer is on the side, but this is a robotic arm that's placed on your thigh bone, and it will position where I want to make the cuts to make it as perfect as we can make it. And the bottom line is to give you the best range of motion with a stable, well-aligned knee replacement. So really, when I speak to my patients, they do want to know about some new technology, and the new technology is not for everyone. You really have to assess a patient by patient individually to determine really what is the best way to do the replacement for that individual. And for knee replacements as well as hip replacement, physical therapy and mobility is very important for the individual. And we want to really return you to function. I was originally trained in Utah, so we did a lot of skiing, and a lot of our patients there wanted to return back to skiing. Now, it doesn't mean you're going to jump off a hill or do moguls, but downhill skiing is very allowable, and especially for my knee replacements, I will allow you to do anything you want to do. The sky is the limit. Really, even for my hip replacement, I have professional dancers, I have some extreme sports fanatics, and they're able to go back to what they really wanted to do, no matter what you want to do. The bottom line is really to have a happy patient. So if you're in pain, you don't just have to live with it. There are options available, and there's much that we can do to make it better for you. Again, you want a happy patient, and that's really what makes it worthwhile for me, for what I do with joint replacements. So let's jump right into it. Now that you have a background of what the joint replacement is all about, let's show you a model essentially of a knee. This is a knee. The thigh bone is on top, shin bone's on the bottom. The kneecap is here in the front. If I move over the kneecap, in a knee replacement, what happens is that you have to cut a geometrical shape in the bone, as you can see here, and you cut a line across in your tibia here. And what you do is you fit the knee with this prosthesis. Now, the white in the middle is the plastic, so now when you're moving your knee replacement, you're moving the metal on the plastic, so you're not grinding the bone on the bone, and that's what gives you the pain relief. Everything else around your knee essentially is your own tissue. In a hip replacement, which I'll show here, we give you essentially a new socket, which is here in your pelvis, and that socket again is made out of metal. It's generally the titanium or tantalum type of metal, which is inert in your body. I like to use a plastic liner, as you can see here, but again, there's other type of liners that can be used. And then you get essentially a new ball with a stem that goes in your thigh bone. Now your hip becomes this new ball in a socket. So where your hip initially grinds and you lose that motion, this hip replacement now allows the ball to rotate well within the socket to give you back that mobility without the pain of rubbing the bone on the bone. And again, there's different type of balls that we use. Some of them are ceramic based, and we can also have modularity of the stem where we can change the necks of the stem, as shown here, to really replicate more of your anatomy. Now, before we move further, I'd like to introduce a colleague of mine and a personal friend, Matt Shelley from Zimmer Capital, and he's really an integral part of my team. When we do a joint replacement, it's not just me doing it, it's the whole team to make sure that what I have during surgery is always there. So Matt, thank you very much for being here.
Thank you for having me.
You've really been with me for several years now, and we're really growing a good relationship because
Absolutely.
we book these cases, we plan on doing things, and you always make sure I have my plan A, B, and plan C. I definitely need a lot of instrumentation, and we're in touch quite frequently.
Absolutely, correct.
If you don't mind just saying, essentially, what do you have to do when I say I need to schedule a knee replacement or a hip replacement?
Well, I first book the case, make sure all your instrumentation and implants are there, whether it's me driving to my office, 30, 40 miles away, coming up with different plans, looking at the x-rays with you, templating the case, just to make sure everything goes smoothly. If we're bringing a new product in, there'll be times where I have to come in with the instruments and educate the staff, just so there are no hiccups or any issues that come along during the day, and make sure day go a lot smoother and benefits the patients and everybody all around.
Absolutely, and that's really what makes a difference. When I'm in the operating room and I see you there, I know I have a backup. If I need something, you're the guy. And you actually brought down for us a specific trays of what I actually use in the operating room to do a knee replacement, a traditional knee replacement. So I'd like to actually show again some of these things here. And here, if you look at a replacement, this is the metal component that we put on your thigh bone right there. And there's different sizes of it. It articulates with a plastic, as you can see here. And again, there's different thickness of plastics. And down at the very bottom, which goes into your thigh bone, this essentially gives you your knee replacement. It's your new surface as you move. You're moving the metal on the plastic for a knee. And what I have here is actually the actual set that I use during surgery. And it's really more condensed down to really what I need to do the replacement. And if you focus on some of this, it looks like a lot of instruments. But essentially, we have different instruments that would help me determine your alignment, because alignment is very important. And essentially, it's a rod that goes into your thigh bone with a jig at the very end, which sits on your distal femur or your distal thigh bone, and it allows me to make the cut that I want. So once I get the alignment where I want it to be, I make my initial cut in the bone. Then I have to size your knee. And when I size your knee, there are different types of sizing that I can do. And you can see just here, these are two all-in-one cutting blocks. So once I place it on your thigh bone and I determine the size, this is placed, and there are different sort of openings here where the saw capture is, and the saw essentially goes in here and makes the final cuts. And the different angles that we make in order to fit the final prosthesis into it. So it gives me the cut so it can fit the prosthesis right onto your bone. And again, we size it to you. So during surgery, we try to find the optimal way to make this the right size for you. And if we look at this tray right here, these are different sizes that we can do. And we can go maybe for the largest first. So you can see, depending on your size, we go from small, very cute, to a very masculine, big knee. Now, it depends, again, on your sizes. And these are essentially going, let's say, from a male size 0 to a male size 5 for your thigh bone. And this is, again, you can see how we cut a geometrical shape in your thigh bone, and then essentially we put the prosthesis in place. And Matt, actually, let's take a look at, let's say, the same size for a male versus female.
Male and female.
So here, these are the same size, which means it's a size, let's say, 4, size 5. But they actually differ for a male and a female, because the anatomy for a female could be different. It could be narrow from side to side, where a male can be, let's say, wider from front to back. So it allows me to, again, make it a better fit for you just based on your anatomy, a male versus a female. Once we did the thigh bone, we do have different trays that go down to your tibia or your shin bone. And you can see, depending on how big your tibia or shin bone is, there are different sizes. You could be very small, or you could be very large. And the size here does not matter. The fit matters. We want to make sure that we cover your bone in order to really give you the best sizing and the best fit for your anatomy. And once we place these into position, what we do is we have different type of plastics. And here, there's different thickness, different sizes. And you can see, before we put the real implants in, again, I'll show you here, there are different thicknesses. So depending on how we want to balance your knee, these are the trial plastics that go in before the real plastic, which I showed you before, which looks like this, for instance. It's white, goes in. So we trial it to make sure it's the best fit first. And there are different colors, again, depending on the sizes. Maybe we can see a green versus an orange. What we have here is, again, depending on the size that you have, will depend on the trials that I put into position to make sure that we try really to kind of to fit you the best that we can. And again, it's about fitting you the best way that we can fit it. Some of the instruments will reach to the kneecap, and some people say, well, I have my own kneecap. The answer is yes, you will have your own kneecap, but we put a plastic underneath, which now articulates with your thigh bone here. So what happens, the kneecap will now glide here, but you have your own kneecap. From the outside, you'll feel it, but from the inside, essentially, here's the kneecap, it glides on your thigh bone. But the bone on the outside is still you. It just gives you a new surface, because your cartilage is worn down, that will now articulate with the metal. So as you bend your knee, that will glide right into position. And again, there's different sizes that we have. Just to show you, when we resurface your kneecap, there's, again, sizes. The orange is the larger one, where the teal here is the smaller one, and we base it on your size. And how do we know the size? Well, we have different instruments that we can actually size you. This is how we think about sizing your kneecap. You can see it's pretty straightforward. It gets larger, and we try to give you the best fit that will fit your knee, as you can see here. Once we find the right size for your kneecap, I have different instrumentations that this goes on your kneecap, and what we do is essentially we ream here to make sure it's nice and flat. We drill certain holes in it, and then it allows essentially these little pegs, which you may see on the very side, to really go in and anchor down to your bone. And the way we do a knee replacement, the gold standard, is actually we cement the replacement into place. It's almost like a grout. It anchors right into your bone and allows the prosthesis to sit right in, anchor it well, and you can weight bear on it right away. Moving the knee is very important, especially for knee replacements. The motion is the number one important thing. And what I tell my patients is, you have to move your knee. You can't just sit there. This is a surgery that you have to work through. The better you work on the motion initially, the better you'll get afterwards. And jumping a little bit back to the hip, there are different stems. And here I can show you smaller stem versus a larger stem. There are different types of stems. Some could be cemented into place. Others are press fit. The surface texture is different per stem. There's short ones. There's larger ones. Here, just between these two, you can see the length can be different between them. And it really is made to fit you. Now, some of these are more type of revision stems or a fully porous type of stem, which means your bone will anchor into the stem and grow into this surface and anchor the stem itself. So this is sort of a porous coating or titanium type of finish to it, which is really the better way to go generally, because your bone will anchor it in for a long-term survival. Then on the stem itself, we have different balls that can go on. Here you can see we put a ball right on top here. And here, for instance, a ceramic ball. Now, it doesn't mean that pink is for women in the hips. Pink is actually the ceramic type. So instead of a metal ball, we use a pink ball, which is a ceramic ball. But they all fit on the stem, just like that. And then we have the cup here. There is a liner that goes into the cup. Again, I use more of a plastic liner, which I don't have in my hand right now. But if the plastic liner is there, essentially, again, this ball becomes articulating with the plastic, enabling you to have all this motion that's there. And there are different sizes of cups as well, working from something that's bigger to something that's smaller. And actually, it does not have to do anything with your outside size. I have very big and large and heavy individuals who have a nice little tiny cute cup. And I have very thin individuals who have a monster cup. So it's really based more on the size of your pelvis and really your bony anatomy once we're inside your body performing the surgery. And here for hips, again, it's something that we need to have backups. And again, Matt, as my rep that's there, he makes sure that I have what I need. Anywhere from different type of stems, or let's say something happens. and we put it in, and there are sometimes complications.
Yep.
Although we always try to really reduce and limit the complication, if you bang things too hard, things can sometimes break. So you have things available to me to fix it. Or if plan A doesn't work, you have a different stem or a cup that we do to fix it too. And you also travel between many different hospitals.
That's right.
So, going back and forth can sometimes be an issue, but you have other people, obviously, that work with you. You don't work on your own independently.
Right. It's a team effort, like you said, all around, where, like you said, we want everything to go smoothly. That's why preoperative planning is big. Talking to you, staff, make sure all the correct instrumentation implants are there, just so the patient is taken care of 110%.
Yeah, and it's something I have patients that come in to say, I've looked it up. I'm interested in having a ceramic head, where I generally do, let's say, metal heads. But that's what they want, and I go through with them to say, well, here are the risks, here's the benefits. But that's fine. If I'm willing to do what you like me to do, as long as that's something that I personally do. And I would generally suggest more of the right things for you overall. But then I have to let you know, because my standard replacements. I like these type of instruments that are there, these type of prosthesis. But then I let you know if a patient wants ceramic or a different type of implant, then I have that available as well. And the inventory that you bring something for it is a lot.
Sometimes can be.
And there could be differences also between right and left, especially for knees. You can't put a right knee and a left knee. So in different sizes. And Matt may not know what I use or the size of the patient initially, what I would end up using. So he brings me all the sizes, whatever it may be, anywhere from a small size 0 all the way to a size 5, which is a very large size, and everything in between.
Yep.
Backups in case there's a weaker type of bone, different type of stems that we can use even for knee replacement, and different type of augments. So that's really very essential for the successful knee replacement. And what you see here, these are really the traditional instruments of really kind of a stripped down set for me. Initially the sets come at multiple trays, but Matt essentially knows what I need for my knee replacements, and he facilitates it by giving me just the stuff that I need. Everything else is sort of a backup, but it's all there, and you can see different sizes, different instruments that are there. They're laid out on the table and ready to go for my knee replacements, and obviously for my hip replacements. And what I really want to also emphasize about knees versus hips, when you have a hip, the main thing is, after a hip replacement, is to get up and walk. That's what I want you to do. The therapy can help you, and some strengthening is important, but really up and walking is what you want. You'll gain that mobility right away because you've lost some of it to begin with. As soon as you got the new ball in the socket, you'll get that mobility. And you can even sit down most of the time, you'll still get that mobility. For a total knee replacement, that's very different. And what I emphasize to patients, even before surgery, you have to work on motion. We can give you the best looking knee replacement and the perfect fit and perfect looking x-rays, but it's based on what your range of motion was before surgery, as well as what you push on your motion after surgery. For a knee replacement, it's not a surgery that you have to sit and wait and it kind of aches. The way we approach it is that you have to gain the motion. And over the first few weeks, that's when you get the best benefit and the best chance to get that motion. And for my patients, I may see them more often than other orthopedic surgeons who specialize in total joint replacement. But it's important for me that you are reaching the milestones that I want you to reach. And if you can't, then I want to try to do whatever we can to gain you back that leeway. It's very, very essential to the success of your knee replacement. And what I do with my patients is I do discuss all this with them beforehand to let them know, look, here's what you have to do. It's a team effort. I'll do what I got to do as long as you will do what you have to do. Because the bottom line for me is that I want success for you. I want you to have a successful joint replacement and be able to go back and enjoy what you want to do. The happier you are, the happier I am. And that's really what makes it worthwhile for me to do orthopedics and joint replacements. And again, we have to really understand some realistic expectations. different deformities that are out there. And there's different treatment methods. I tend to be a little more conservative initially, which means we're going to try everything non-operatively first. Now, you may walk in and your deformity is too far gone. Your x-ray shows you're bone on bone. There is nothing else that's left out there except a joint replacement. But others, and I've seen some patients who come to me saying, I need a knee or hip replacement. And I take a look at it, and it's actually, that's not it. The physical examination is very important. You can have things like tendinitis and bursitis around a joint that if you treat that, all of a sudden your joint feels better. So you have to really make sure that you're treating the right thing. In today's healthcare, and again, this show is your healthcare, the more that you understand, the more you refer to your physician, and the more information you give your physician, the better it is for us to understand really what's bothering you and what's going on and what we can do to really help you be better. Now, dealing with arthritis, the more you know about arthritis, the easier it is for you to make that decision. And I put it all on the table. When you're out there and you're a candidate for a hip replacement versus a knee replacement, we'll go over it with you. We want to make sure that you understand it is surgery. There's risks associated with any type of surgery. We generally do it when the benefits outweigh the risks. But we have to understand really what it implies to have surgery once you move from sort of the non-operative type of treatment. We'll take a very short break and we'll come back to recoup on arthritis and the update in total joint replacement. Stay tuned. I'm Dr. Amit Lahav. This is Your Healthcare. I'm Dr. Amit Lahav, and today in our show, we discussed arthritis, the different types of arthritis you may have, different type of treatments, starting from the conservative and non-surgical treatment. And there are things that we can do to make it better for you. It all depends on the progression and the severity of your arthritis. All the way to hip and knee joint replacements. We've gone over some of the updates, even robotics, custom-made prosthesis, different ways and techniques to do the surgery in order to make it the best thing for you. Be it a hip replacement that you may need or a knee replacement that you may need, the best thing is to try to make it the best for you at the index procedure, to make it the best fit and really understanding what this means. It's not for everyone, and it can benefit the right individual at the right time. What I generally say is you have to be ready at the knee or the hip, but you also have to be ready up here. The more you know, the better you will be about making that decision for yourself. I'm Dr. Amit Lahav. This is Your Healthcare. Thanks for watching our show on arthritis and total joint replacement update. I want to thank Matt Shelley from Zimmer Capital for being with us here today and really bringing the real stuff to show you how we do orthopedic surgery. I'm Dr. Lahav. Have a good weekend, and we'll see you next time.